Has anyone had the pleasure of being a patient at all, having an overnight stay in hospital? Yeah, few people, okay. So even in one overnight stay in hospital, your story will be passed on at least 10 times, okay, by different clinicians over and over and over again. So you sort of get this feeling of, information being transmitted between lots of different people, and a lot of that gets lost along the way and errors are made, okay. So it's a really vulnerable point in patient care, and the errors can be devastating for patients. And I have witnessed this firsthand in my 20 years of clinical experience, which is probably why I'm so passionate about this, and it's what I'm trying to instill in my students, is applying some critical thinking around this process so that we can reduce the errors that are being made. The scale of the problem is massive because we have millions of these episodes occurring annually. And on top of this, we've got increasing patient complexity as we've got a growing burden of chronic disease all around the world at the moment. So in light of this, nurses need to actually switch on and not switch off during handover. And there's evidence to show that if handover is an active process rather than a passive process, errors are reduced. It creates a space for learning and it creates a space for asking questions rather than just a sort of passive one-way transmission of information. So the RSD framework was used as a tool to stimulate students' critical thinking and clinical reasoning ability in this process. And what I found from using a tool was that students were able to identify patient risks and articulate their concerns about patients. They were able to construct questions to ask about patients, which is something they're often quite too intimidated to do in a clinical environment. And they were able to analyse the information that they were being given. So my talk here is more about the practical application of the RSD framework, and I do want to follow that up with some formal evaluation and research in the future. So clinical handover, what is it? So it's a transfer of the accountability of care from one clinician to another. That's the simplest format. And we do have a framework called ISBAR that's been around for quite some time now, and that's used to facilitate the process, and it's basically used to help people organise the information they need to give and to create some consistency around what clinicians are doing, basically. And it was first used to help people in emergency situations. So, for example, if I was working on night shift in the middle of the night, my patient deteriorates, I need to call the doctor. Sometimes you feel a bit intimidated to make that phone call, say, oh, I'm really sorry to bother you, and it's to try and stop that sort of, behaviour and have this, hello, my name is, this is the patient, this is what I need you to do. Okay, so it really gives you that confidence and provides a framework. And we teach students about ISBAR, but what I find is it's quite mechanistic. And it's actually a taken for granted skill. So it's not taken any further than that. They just learn ISBAR, they rote learn it, and it's quite mechanistic, it's quite passive, there's no shared dialogue, and I really think we need to take it a step further and look at, what questions are students asking at a handover, what do they want to ask? And sometimes students aren't aware of what they don't know about the information they're being given. So they've been given all of this information and they're sort of like, yep, and they walk away and they're going, oh my God, which is what really happens in reality, right? And I've been there myself. I've been on a new ward, and everywhere you go has different terminology. So you go to a different ward where you've never been before, and bearing in mind our students have 2 weeks on a ward, where they've got to go and be orientated, they've got to learn the language, because language isn't universal across the hospital. Every ward has its own unique language, so you've got to go and learn a new language all over again. So you can see how hard this would be for our students. So we'll just move on to the next bit. In the first part of the workshop, we used a stimulus as a clinical problem to try and get the students working with their critical thinking skills before we moved on to the next part of the workshop. And so this is a clinical problem. There's no really right or wrong answer to this, although I would tend to say that it's probably right. And the students use the facets of the RSD framework to sort of have some debate and discussion about this. And this brought up some really interesting themes about where our students get their information from. So some of it is clinical practice experience, some of it is clinical observation, the rest is clinical guidelines, so accessing guidelines that are in hospitals, and research and education. That tends to be their pool of gathering information. So we started off by doing that, and then The students were provided with a handover, and it was a video recording of a handover. And they had to take down the handover, and it was given in a sort of way that it would be given in a clinical environment, and students had to sort of take that information down, and we start using the RSD framework facets to really pick apart what do I understand, what don't I understand, what questions do I need to ask, why do I need to ask that question, what's my rationale behind it, and all of that sort of stuff. So it's really good. So I just want to give you a bit of a feel for what this feels like for students. So I'd like you to grab a pen and a piece of paper. And you won't be familiar with all the language I'm going to use, but I'm just going to give you a little taste of what it feels like to receive a handover. Okay, so you ready? You listening? Got your pens ready? Okay, so this is Mrs. Appleby. She got some mid-scapular pain while she was out walking her dog this morning, and some associated shortness of breath and sweating. She sat down on a bench for 10 minutes. The pain didn't go away, so she called an ambulance. The paramedics turned up. They gave her 600 micrograms of GTN. That didn't change the pain, so then they gave her 5 milligrams of IV morphine, which took the pain down to a 4 out of 10. She then went to the emergency department, which they gave her another 5 milligrams of morphine, which took the pain down to a 2 out of 10. They did some ECGs in the emergency department, and they were normal. Her past history is anxiety, depression. She's had left breast cancer with axillary node clearance, and 8 cycles of chemotherapy. She's had a hysterectomy for fibroids. She has hypertension and type 2 diabetes. So you get the picture? Yeah? How's your shorthand going? All right. So that's just sort of half a handover of one patient, okay? Bearing in mind, students will probably get 4 of these at least. Okay, it's a lot of information, isn't it? And I know that some of you probably don't know the language, but neither do the students, okay? So you can see why we're trying to build a framework around this process, okay? So this is the Pentagon. So it was a bit clunky using this for the first time, I won't lie. It got a bit confusing, and trying to arrange the facets into some kind of order, because a lot of these can be applied to all different aspects of the handover process. So it was quite hard, and it was a challenging semester. I couldn't get enough of these workshops in succession to actually build and scaffold the complexity as we went along. So next year, I really want to be able to get some, consecutive workshops so that we can actually keep doing this consistently, and students can become familiar with it. And Embark and Clarify, though, was quite clear. And under that, even, what is my role in the handover process? So who am I accountable for here? Am I a student with a mentor? What's my level of accountability? And actually, we had some really good discussion, and this just shows that we need more education on just the handover rather than just ISBAR, is the social and political aspects of handover. Yeah, so the bullying and the intimidation that can go on. So if you're feeling really intimidated and bullied by the person that you're giving or receiving handover to, that affects the quality of the information that you're able to give and receive. So some really, really good, honest discussion. I think the students were actually quite relieved to talk about it and go, oh, I hate doing that. I feel so intimidated. If you feel intimidated, you can't really listen, you can't really switch on, and things happen. So what else have we got there? My level of accountability, organising and managing. So we do have the ISBAR framework to support that process. Analysing and synthesising. So, do I understand this information about this patient? Even just asking that question, because sometimes, like I said, they don't really know what they don't know sometimes. So it's sort of trying to unpack some of that. What does this information mean? Really, really important. So what can I predict about this patient? X, Y, and Z is going on. What does that add up to? Where is this patient likely to go? What's likely to happen to them? What conclusions can I draw about the safety of my patient? What questions do I need to ask about this patient? So I really would like to do some work and analyse the types of questions they are asking and why they're asking them, and then do that again when they go out on clinical practice and actually see what kinds of questions they're asking at handover to see if there's any translation across, because I guess that's the ultimate goal of what we're doing. There's no point doing it in the classroom if it doesn't translate across there. Okay, so there's some of the questions that came up. I particularly like some of these comments from the students. So something I would like to clarify is what information giving in the handover is most important compared to which information is either irrelevant or just something to note but not pay much attention to. That's so hard for students. So hard. it's good, for, easier for expert nurses to do that. You filter in and you filter out, a bit like when you're listening to something like this. Okay, yeah, that bit was good. Forget the rest. There was one sentence. So you kind of know your alarm bells go, okay, I'm going to store that there, and I'm going to put, the rest of it over there for now. And I really like the bottom one as well. So she's fit to go home according to the night nurse. So we need to question what investigations were taken prior in the day. So that's like, I'm not just going to take at face value that she's safe to go home. I want to know that she's safe to go home. What tests has she had done? How is she getting home? All of that sort of stuff. So I think the bottom line for me is really getting students not to just take the information they're being given at face value, because it's really dangerous, and I've seen it have really poor outcomes for patients. So I think that's where I got to. I've already talked about what I'd like to do in the future in terms of formal evaluation between the classroom and the labs, and then students going out into clinical environment so that we can improve patient safety. Thank you very much for listening.